what we found 9 years ago is a chemical which is called fractalkine, which is extremely sensitive to pure stress, non-traumatic brain injury.
Welcome back to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host today. My name is Dr. Scott Sherr, and it's a pleasure to be with you. I have a fantastic guest. His name is Dr. Mark Gordon. I've known Mark for many years, and it was really fun to have a really expansive conversation with him. Here's a quick bio, although there's a lot to say about Mark. He's originally trained in family medicine, continued his medical education in clinical orthopedics, cosmetic dermatology, and sports medicine, prior to culminating in interventional endocrinology in 1997, a term which he coined in 2003. He has been involved in multiple things. He was instrumental in increasing the recognition of traumatic brain injury as a cause of hormonal deficiency in the hallmarked presentation on ESPN's Outside the Lines in 2007. His first book, The Clinical Application of Interventional Endocrinology, is recognized by his peers as a dissertation on the standards of care and assessment for hormone replacement medicine. His academic standards and medical knowledge have been recognized by USC, where he holds a voluntary position as associate clinical professor at the USC Keck School of Medicine. He's been a consultant to multiple different shows on HBO, CBS, ESPN, CNN, Fox News, and others. And in 2004, he was recognized the association between TBI, hormonal imbalances, and neurobehavioral conditions. Now he lectures, he works with veterans. He has a book in 2015 that he released called Traumatic Brain Injury, A Clinical Approach to Diagnosis and Treatment. He works mostly with veterans now, and along with Andrew Marr at the Wounded Warrior Foundation. So Dr. Mark and I had a great expansive conversation on multiple things, including traumatic brain injury versus non-traumatic brain injury. We also spoke about why Mark doesn't believe there's anything such as PTSD. It doesn't exist. We talked about almost all the hormonal axes as well, not only in brain injury and non-traumatic brain injury, but also in hormonal optimization itself. Mark and I discussed the ideas of optimizing hormones like testosterone and clomid and growth hormone and IGF-1, thyroid hormone, and we talked about neuroinflammation and how all of these things work together to optimize the system, and how you can do a lot just without hormonal optimization to see significant improvements in brain neurochemistry. And we spoke also about Mark's programs, including the nonprofit organization that Andrew Marr works with in corresponding or with Dr. Gordon in ways to help veterans and doing some amazing things giving back to the community. We also spoke about Mark's new projects and how he's working at multiple different state and governmental levels, which is super cool to see that some of this is really coming into the mainstream. Hope you enjoyed this conversation with Dr. Mark Gordon. We had a really fantastic time. This podcast is also brought to you by Health Optimization Medicine in Practice, a nonprofit organization that's training doctors and practitioners on how to optimize health rather than treat disease, along with Transcriptions, a precision dosed pharmaceutical grade and physician formulated brand of supplements or formulas that help with focus, brain optimization, mitochondrial health, stress, anxiousness, and more. Enjoy the show. All right, Mark, it's good to see you.
Hey, it's always good to see you. I like the beard.
Yeah, I moved to Colorado, so this is kind of part of the passport. You know,
are you in the rustic area?
It's all rustic here in Colorado. Come on. I know you're on your way to Texas, and you're going to have your 10 to 15 guns and ammo supply, I'm sure, coming soon.
Absolutely.
Well, it's good to talk to you. What's that?
You bet yourself. Definitely.
Oh, you're using some sort of Texas slang that I don't even know, do you?
Well, I'm starting to learn them. You know, I've got Andrew Marr and his entire family trying to teach me how to, migrate to Texas other than body, but spirit and language-wise.
Yeah.
So I've got a translator now. You know, we've got Spanish, French, and German. We've also got Texas.
Beautiful. Yeah, I love that. Yeah. So, Mark, you and I go back a while, and I've always been a real big fan of your work in traumatic brain injury and in the world of PTSD, which you don't believe in, which I love. So I wanted to start there. As far as I know, you've been controversial in this world, but why don't you believe that PTSD exists?
That's a great question. One of the things I do believe is that TBI, undiagnosed, or TBI untreated, leads to an accumulation of symptoms that they're calling PTSD. So the reason why I don't really believe in PTSD, because the premise for PTSD is that it's exposure to some kind of an emotional, stressful, environmental situation, whether or not it's out in the field of battle where you see your your teammate being shot or killed, or else you're in a household where you have a very stressful parental environment, or you're in a scenario where you're always being accosted or threatened, which creates this state of stress. So what we found 9 years ago is a chemical which is called fractalkine, which is extremely sensitive to pure stress, non-traumatic brain injury, the stress kind of things. And this chemical called fractalkine is produced by the nerve cells, the neurons. And what it's supposed to do is to keep the inflammatory producing cells called the microglia, it keeps them in their quiescent or in their sedentary kind of state, surveillance state. But when you have stress and cortisol levels rise, it shuts off the neuron's ability to make this chemical fractalkine. So what happens is the inflammatory, pro-inflammatory producing cells, the microglia, can start producing and dumping inflammation. So these inflammatory cytokines create free radical damage. The free radicals keep this catch-22 going, where more of the cells are activated from M0 to M1, and they start dumping and altering the biochemistry of the brain. So now you've got a scenario where this chronic stress has altered the chemistry of the brain, and now where are the susceptible places in the brain that's going to become affected by it? And that's something that we call biological resiliency, where because of things that we do in life, we can have areas of the brain that are fortified by eating well, drinking well, exercise, no alcohol, good supplementation with, tocopherols and fish oil and so forth and so on, which puts on another layer of, we'll call it Kevlar. So it's like putting protective layers by what we do correctly, exercising with brain-derived neurotrophic, even cold submersion. The Wim Hof thing actually stimulates some important brain building chemicals, neurotrophic factors and growth factors. Mm-hmm. So what happens in what I'm reading and interpreting is that when you change this environment of the brain from a neuropermissive to a neuro-non-permissive, where it's damaging, there are certain areas of the brain that are more susceptible than others to the influence of these dampening, damaging chemistry of the brain. And the most important one is something called peroxynitrite. Peroxynitrite is what's made from free radical called reactive oxygen species, and it steals from our blood vessels nitric oxide, which is important to keep the blood vessels dilated. So when you see a SPECT scan, what you're actually seeing, those punched out areas, are areas where the reactive oxygen species has stolen the nitric oxide, and you have vasoconstriction as opposed to vasodilation. Sure. So that's what the punched out areas are. So, what the literature supporting PTSD tries to do is say, okay, because this area and this area and this area are damaged, that's PTSD. And because this area and this area are damaged, that's TBI related. Well, I feel that it's really, based upon the biological integrity of the individual and their defense systems. Glutathione, it's the first defense line that we have against neuroinflammation, and it's the fastest one that is removed. But if you're taking in things like N-acetylcysteine, glutathione, and vitamin E, gamma tocopherol, it can help regenerate. Vitamin C also helps to regenerate it. But if your nutrition is devoid in that, there are areas of the brain that are more susceptible to the damaging effect. And that's why I believe that there's this dichotomy between what we believe TBI is and PTSD. But it all goes back to the neuroinflammation and this biological resiliency is my belief.
Right. So I think really what you're saying is that, at least as I interpret it, is that there's two different types of brain injury. There's traumatic, and then there's going to be non-traumatic brain injury. Right. And so the PTSD world, or that actual condition, would fall mostly into the non-traumatic brain injury area, although there's going to be crossover, right?
Yeah, there's a big overlap, and the every single one of our veterans that we take care of have a diagnosis of PTSD, and some of them don't have a diagnosis of TBI.
Right.
But when we do their biomarker panel, there are certain patterns that are definitively pointing at trauma as a precipitating causation. So, as I said earlier, my belief is that PTSD is a missed opportunity to have treated a TBI, and it's just
Right.
progression down the line. And so every
Right.
one of our vets who are given have a diagnosis of PTSD with or without TBI as the precipitator, they all get better when we put them onto the TBI protocols, because the TBI protocols addresses that inflammation, helps to reestablish fractalkine, helps to encourage the neurosteroids, the hormones in the brain, to come back online, because they have very protective roles to play in the brain that are now being listed, being shown through research.
Mm-hmm. So a lot of questions. The first one that comes to mind is patterns of hormone dysregulation that you see in trauma that are very diagnostic for you.
Yes. The most common one is growth hormone. When you look at the studies that have done, they find that after TBI, growth hormone deficiency occurs. It turns out that growth hormone, testosterone, estrogen, and thyroid are very susceptible to the brain, inflammation in the brain. And I sent out to our journal club, which I know you're part of, an article last year which talked about how inflammation disrupts a cell called an astrocyte. It's part of the glial system, a glial cell that's responsible for producing a chemical to help the hypothalamus, the area that produces the trigger for the pituitary to produce follicle stimulating hormone that helps with fertility, and with luteinizing hormone that helps with the entire cascade of our steroid hormones going down, to testosterone, estrogen, progesterone, and so forth. And it's this inflammation that disrupts the communication between astrocytes, the hypothalamus, so it cannot send the signal to the pituitary to produce our hormones. So what we've been able to do, we have a small pilot group of 9 vets where only thing we did was put them on anti-inflammatory products, nanoliposomal delivered anti-inflammatory products, nutraceuticals. And what happened was their testosterone doubled and tripled. So growth hormone, believe it or not, needs estradiol in the brain for growth hormone to be produced. So you might see women who are on birth control pills, or women who have very high levels of estradiol, or a woman that might have PMS because her estradiol is higher than her progesterone level. They have very high levels of growth hormone because of the relationship between estradiol stimulating or helping the area of the brain, paraventricular nucleus, or is it the arcuate, for producing the growth hormone. Also in the liver, you need to have growth hormone and estradiol to stimulate IGF-1, which is the major active hormone below the neck. And we see this happening, or the effect of stopping estradiol, when we use something like Arimidex, or we use tamoxifen, or we use clomiphene citrate. What we'll see is the entire growth hormone system is working well, except the deficiency of one product, and that's IGF-1, that we call the clomiphene effect. And,
Interesting.
So that it's influencing the liver, which is 75% of our growth. IGF-1, IGF-2, binding protein 1, 2, 3, 4, 5, 6, 7, and acid labile subunit are all generated in the liver, 75% of them. And estradiol, extremely important for IGF-1, which is the one that helps with protein synthesis, sugar, with absorption of amino acids from the gut along with growth hormone. So the other is thyroid. And what we've been able to find, and it's came out, I think, 11 years ago, called the Jostel Index, commonly called the TSH Index. It's a mathematical model that looks at TSH produced by the pituitary and T4 produced by the thyroid gland. It's a mathematical formula, and what they found is if the calculation ends up being 1.3 or less, the dysregulation of thyroid function is coming from the brain, and that's usually from trauma. and in a major amount of our veterans with blast trauma, whether or not it was IED, mortar shell, scud rocket,
Right.
shoulder-mounted munitions, whatever, they'll have this 1.3 or less. On the other hand, if it's 4.1 or greater, the problem's coming from the thyroid, whether or not it's thyroiditis, Hashimoto's thyroiditis, or primary hypothyroidism. That can be picked up. So what you'll see is TSH will be elevated, and the TSH index will also be elevated proportionately, and that is a classical primary hypothyroidism.
Right.
If you look at reverse T3 with that, you can also predict Hashimoto's thyroiditis. So those are the three: the growth hormone, the testosterone because of the astrocytes, and then the thyroid because of the central or peripheral insult to the system.
Mm-hmm. Okay, and then so what about let's call it the non-traumatic brain injury category? And so I mean that's probably a huge category. How do you think about this category, and how do you approach it? It's obviously easier, like a guy comes in 10 blasts like Andrew Marr or something, and he's got a brain injury. It's obvious, right? But then other people that have more on the other side of your categorization here, how do you approach somebody with what you believe is a non-traumatic brain injury, and then what does that look like?
Yeah, believe it or not, things like surgery, okay, things like someone who has a non-head orthopedic injury, so they broke their tib fin, and that will generate inflammatory cytokines that go right into the brain and create a problem. Another one, which is now going out there, is the gut-brain connection. So you can have dysbiosis because your bacteria are off. You can have alcoholic dysbiosis, medication dysbiosis. You can have allergic. You can have leaky gut. You can have, ulcer, and that will create an elevation in cytokines, these pro-inflammatory cytokines that go right into the brain. And if you look at some diseases like, what's a good one? Psoriatic arthritis, rheumatoid arthritis, psoriatic arthritis, Crohn's disease, those autoimmune diseases, what is consistent with them is a high frequency or high rate of depression. And that depression is due to the inflammatory cytokines disrupting the chemistry of the brain, leading to those sensitive areas is number one. And also it shuts down the production of serotonin and melatonin. So what's very common is these inflammatory cytokines, when they get into the brain, they interrupt enzymes. And one of the enzymes called L-tryptophan hydroxylase is responsible for taking L-tryptophan to serotonin. So if you don't have that pathway, you're depressed. And serotonin gets converted over to melatonin. So that's L-tryptophan decarboxylase. And that's very sensitive to inflammation. So you end up getting insomnia. So you've got classical for our vets and our civilians: insomnia, depression, and fatigue. Where's the fatigue comes from is the buildup of tryptophan, just like happens when we have Thanksgiving dinner. And then that tryptophan, when it reaches a certain level, gets converted to, I think it's called nilarixic acid, which is toxic to the brain. Okay.
Interesting. Yeah, I mean, so the whole workup really, when somebody comes to your office, really requires an understanding of which kind of category they fall into to some degree. But in the end, you're probably doing, I mean, obviously you're looking at hormones, but you're also looking at, what else are you looking at otherwise, other than hormones, when somebody comes in?
We look at general chemistry, so we make sure there's nothing with the complete blood count. So cellularly, we look at liver function, we look at kidney function, we look at parameters for diabetes, because how the insulin-resistant type 2 diabetes is very important because you can create that under stress. We look at vitamin D level because of all the science that came before COVID already told us how incredible vitamin D is, and now they're talking about vitamin D for protecting your heart. There are over 1 million articles, or over 2.5 million articles on that.
Wow.
Vitamin D is
Yeah.
a miraculous drug. It helps to stabilize the immune system. It now has been found. Next week, I'll be sending out an article that talks about vitamin D and regulation of Leydig cells for testosterone production. If you
Mm,
don't have
mm,
good vitamin D, you can't make testosterone.
mm.
So it's in every avenue. It's in autoimmune diseases, cardiovascular diabetes, endocrine, pain, insomnia. They found low levels of vitamin D associated with greater pain and greater insomnia.
Well, let's talk about that for a minute, because people think vitamin D is just from the sun, right? We just get
Right.
vitamin D, and we just need that for our immune system, maybe. But what are the mechanisms in the brain that we understand as far as how vitamin D is working?
Yeah, vitamin D also regulates the production of cytokines. Cytokines, these pro-inflammatory chemicals from our immune system in the brain. Vitamin D helps to modulate the immune system's reactivity. So you can have an overreactive system if your vitamin D is low. And they keep on proving this by showing that when you're deficient, you've got all these interleukin 1, interleukin 1 beta, interleukin 6, tumor necrosis factor alpha, and you have interference with your testosterone and estrogen. Why is that important? It turns out that testosterone downregulates interleukin 1, 6, and tumor necrosis factor alpha, and upregulates interleukin 10, which is the strongest anti-inflammatory cytokine produced by our glial system. So, and estradiol drops MAKP or MAPK and helps with inflammation. So that's the benefit in Alzheimer's. Why women who have great levels of estrogen, estradiol, and progesterone, why their risk for developing Alzheimer's or cognitive impairment is less.
This study just came out, right? This is a new study that was
Well,
even
there are more and more studies coming out, but they've
right.
been coming out for 10, 15 years.
I know you've been sending them forever, but it finally got into the lay press that if you take estrogen, it's going to give you less chance of having dementia.
Correct.
Also, I mean, interesting for us, of course, is on the blood flow side of things, right? Like the Alzheimer, the new studies on Viagra, for example, increasing blood flow to the brain also has an enhanced effect of a preventative effect against dementia as well, interestingly enough. But the mechanisms of estrogen are super interesting as far as how it's doing that and how it's overall creating more of an anti-inflammatory ecosystem, right? And that's how you think about it?
Yeah, it's not only is it anti-inflammatory in the entire gestalt of degenerative diseases in the brain, Alzheimer's being the most important one, but it also, estradiol, testosterone, progesterone, allopregnanolone, upregulates a transport system called neprilysin, which helps to get the beta amyloid, which they believe is the cause for Alzheimer's. It helps to transport the beta amyloid out of the cell. So if you're a perimenopausal woman without any symptoms of menopause, the endocrine world is now suggested, the articles that have been coming out, not to treat them. Not until they have symptoms. And I'm saying, wait a second, we're going to wait until their Alzheimer's starts before we treat them, knowing all the science that we know? Don't you think we're proactive? We should be proactive instead of reactive. So all our patients, they get tested. If their levels are low, and let me restate this. It's a fallacy to believe that a woman who is perimenopausal or menopausal, like a male, should have low levels of testosterone or low levels of estrogen, testosterone, progesterone in a woman. And what we do is we bring them back to levels that are, in their 30s, 30, 35.
What's your goal level typically for
great question.
Yeah.
Our goal level is not about estrogen, progesterone, or testosterone. It's about the markers that tell us if we have adequate amount of hormones in our body, which is FSH and LH. Yes. There's a whole series of articles talking about, they call it collocation of luteinizing hormone and follicle stimulating hormone as predictors towards Alzheimer's disease in one group of articles. Another one is as predictors in a cognitive decline. So when your FSH and LH are elevated, why are they elevated? They're elevated because you don't have sufficient amount of testosterone, progesterone, and estradiol and testosterone. Right. Yeah. Right. So what we do is we give them a safe dosing, and we monitor the FSH and LH. And when that starts coming down to normal, we have women who have levels of 130, on FSH or
Yeah.
79 in LH, and they should be below 10.
Right.
So what we do is we adjust their testosterone, their estradiol and progesterone, until we see the level of FSH and LH start coming down, and we just monitor it. So when we get to this about 10 range, we know that the dosing they're getting and their blood level is optimal for controlling FSH and LH. So in the articles, and I sent out a couple articles last year talking about this, if
Yes,
you
I
want
read
them
them.
again, I'll
Yeah.
send them out again. But they're
No. Yeah.
not one article. There's a whole group of
Yeah.
articles talking
Yeah.
the same thing.
I think that's the key, is that so many people, I mean, again, I have so many questions and thoughts here, but like so many people think that the end all be all is your testosterone level, right? Or your DHT level. But the challenge is that, and it seems like all the research is showing that if you depress your FSH and LH levels, that's a bad idea too. You want to be in that sweet spot so you don't fully suppress the endogenous secretion of these hormones. Even if you're even postmenopausal, right? You're still going to have some secretion. And even if you're, and the other thing that kind of comes up for me is that, it's often thought that only women go through menopause, but is there equivalent that you see in all men, all comers? What would you say?
Yeah. Guys go through menopause. Okay.
Menopause. It's
Go
called
through
andropause,
menopause. Yeah.
menopause.
Andropause, menopause.
I like menopause.
And what happens is, if you look at the literature about cognition, about dementia, about physical activities, you see that there's a denigration or a diminished functionality when you have diminished levels of these hormones. And one of the greatest fallacies for me is that as we get older, we're supposed to expect that our hormone levels are lower and we just suck it up as being normal.
Right.
I don't believe that, because the longer we live, the more we're exposed to both traumatic and non-traumatic insults that do what? They alter the chemistry of our brain. Okay?
Right.
So the fact that the statistically, we did a sample survey of 1,070 to 79-year-old males, and their testosterone levels are 0, and that's normal. Well, the reason why it's 0 is because of all the traumas they've had.
I don't want to be normal.
It's not normal. So we have people that we correct their testosterone to a level between 25 and 35 years of age is our goal.
Right. Okay.
And sometimes we don't need to get it to that median of that range. The median of the range for 25 to 35. For us, free testosterone is 15. The scale is 3 to 27. Mm-hmm. So we get it up to 15. We won't go higher than 20, but all our labs are always between the reference ranges for a healthy 25 to 35. And that's where we get our benefits. That's how we get, our vets who were depressed, anxious, suicidal, lack of libido. We get them back in the game of life.
Right.
That's the goal.
That's the goal for sure. And certainly, why do you want to be normal with no testosterone when in the age of 70, right? And I talk about this with my clients too. It's like, you don't want to be normal for a 70-year-old. You want to be normal for a 20 to 30-year-old, or 25 to 35-year-old, because that's when you're at your highest potential to do everything and be the most resilient as you can be, as we know from who fights wars, who procreates, et cetera, who does all the extreme sports, who does all of the crazy things on TV. I mean, that's for sure. One thing I think that gets lost in all of this is that you see a lot of people, and you mentioned this earlier, that they're taking testosterone, for example, then they have to be on anastrozole or Arimidex because their levels are too high, and levels of estradiol and estrogen are too high. And so, what do you say to that side of things? In two fronts. One is the importance of estrogen for men, and the other in the sense of why that's not necessary most of the time.
Yeah, great question. It's the battle I've had for since 2007, 2008. First thing is testosterone is not the panacea.
Yes.
Number one.
Agree.
Also, if you take testosterone, you shut off 35 brain hormones, neurosteroids. And the literature documents that within 4 to 6 months of only being on testosterone, you'll get worse. You'll go back to the doc and say, hey, doc, In the beginning, I felt wonderful on this regimen of testosterone. I don't feel as good right now. What does the doctor do? Increase the testosterone. They go good for about 2 more months. They come back and they say, Doc, I'm feeling terrible. I'm not sleeping. My libido's gone and blah, 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 blah. And that's because you've shut off luteinizing hormone, which is responsible. It's the key hormone to make all your steroid hormones. So you lose DHEA, pregnenolone,
Right.
allopregnanolone. You lose all those
You can
things that
see
are
it on the pills.
responsible
Yeah.
for keeping the brain functioning. Number one.
Yes.
Number two is by giving testosterone. Well, the analogy, which you are well aware of because of quiet explosions, is that it's like you have 4 tires and you need all 4 tires filled appropriately in order for your vehicle to go through life, for your body to go through life. And testosterone is only one of the tires. Thyroid, cortisol, and growth hormone. These are extremely important. You need all of them. It's how often we both see clients that come to us from other centers, and they're on one hormone, or else they're on, testosterone and growth hormone, and they're not on DHEA and not on pregnenolone to compensate, or they're not on a secretagogue to help keep the balance in their brain so they don't shut down their own growth hormone production. So there's a lot of preventive things that need to be done. Okay, getting to the Arimidex issue. Why do you need Arimidex? The reason why you need Arimidex is because your level of testosterone exceeds your biological need. The system is telling us, hey, you're putting so much testosterone in, I don't know what to do with it. Let's put it down the DHT pathway. Let's put it down the estradiol pathway because we've got way too much free testosterone. Why is that important? Well, it turns out in some people with elevated levels of free testosterone, when it gets into the brain, it just diffuses into the brain. When it gets into the brain, it can trigger an increase in another chemical called adenyl cyclase. And that adenyl cyclase will cause you to be hyper, like someone IV'd you with methamphetamine speed. And that's why you can see agitation, edginess, emotional volatility when they're on testosterone. And that's because they're unique in having this sensitivity in the brain for free testosterone going to DHT, going to 3-androstenedione, and then going to stimulate the adenyl cyclase, which really upregulates cyclic GMP, which is what causes the problem. So you have to take that into consideration. So the use of anastrozole or AIs in blocking the conversion of testosterone to estradiol, you lose growth hormone. Look at your people who come in on anastrozole. You'll see their growth hormone, their IGF-1, they're down. And then, who is it? Dr. Abraham Morgenthaler from Harvard and then from Boston U, the guy who coined the term low T syndrome. He gave us an incredible lecture on how important it is for estradiols in males. And it's because of libido, growth hormone, endothelial nitric oxide synthetase, the ability to make nitric oxide to keep your blood vessels dilated so you get blood flowing. Your libido center, protection of the lining of the arteries, the heart, the bones, and in the liver, as I said earlier, growth hormone and estradiol help to make IGF-1.
Right.
Okay, so you've got all these parameters. Oh, neuroplasticity. How can I forget that? Estradiol and neuroplasticity. You have an issue with your brain. You have a mild stroke, or you have low oxygenation, or your body is trying to keep your hippocampus, keeping your memory, recall, and the ability to learn new things active in the hippocampus. Estradiol plays a major role in that, along with testosterone, along with growth hormone, along with thyroid.
Right. So it's all your wheels of the tires. It's all of the car, right? And the key, I think the key is understanding this from a network wide perspective. And I think that's the real challenge that we find in this hormone optimization world, is that you have these TRT clinics, right? That's what they do. They replace testosterone, and then they come to you or they come to me, and then we have to kind of pick up all the pieces that have been unfortunately been thrown on the ground for multiple years or even decades at times. So I find it super interesting. I mean, one of the things that I know, I think I've heard you talk about before also is also on the testosterone side of things, in the sense of what's physiologic dosing of testosterone versus hammering people every 8 or 10 weeks with huge doses? How do you typically, and I know you also don't use just testosterone. Sometimes you'll use Clomid as well, depending on other factors. How does that play into your decisions with how to kind of work on that
Right.
angle?
Yeah. For 17, 18 years, the first go-to was testosterone, along with DHEA and pregnenolone.
Right.
But in 2014, because of the Department of Defense changing their guidelines for active military getting testosterone, we had to look for another alternative. And that alternative became clomiphene citrate.
Okay.
And so in 2014, we did the 3-year study, 14, 15, 16, on clomiphene. And what we found was a pattern of dosing, pulsatile, every 72 hours at bedtime,
Okay.
of 50 milligrams. And we had incredible raised levels of our elevation in levels of testosterone and no side effects.
Can you just give a quick mechanism of action for clomiphene for people?
Sure. What clomiphene does is it fakes the hypothalamus into thinking there's no estradiol. And since there's no estradiol, what the hypothalamus is responsible to do is to increase estradiol. How does it do it? It releases something called gonadotropic releasing hormone that goes to the anterior pituitary, stimulates the gonadotropes to produce FSH and LH. So you can get an increase in fertility while you're getting a bump up in your production of testosterone. And the LH goes to the Leydig cells of the gonads and stimulates the production of testosterone. The FSH goes to Sertoli cells and stimulates sperm production. Okay, that's how Andrew ended up with twins. His child number 6 and 7.
Yeah, that's crazy. Yeah, I know.
Yeah, so that's how I go to clomiphene citrate first. It's a long, convoluted kind of rationale because there are 3 different components there. The reason is, as I said earlier, trauma, inflammation shuts down your ability to make gonadotropic releasing hormone. So do I want to commit this 27-year-old veteran who has a wife, no children? Do I want to put him onto a drug, injectable testosterone, which will possibly wipe out his ability to be fertile? Mm-hmm. Or do I want to, one, address the inflammation that's causing him to shut down and stimulate the hypothalamus to produce gonadotropic releasing hormone and get his testosterone and fertility to where he wants it to be?
Right.
So we're actually working with the system, and that, we've been calling biological integrity. We've been keeping the integrity of their system so that they eventually can get off of the Clomid, and that's what we've done. We've treated people with anti-inflammatories. We got a pilot of 9 people, just anti-inflammatories, no Clomid. They doubled and tripled their testosterone in 90 days to 180 days.
Right. You and I have discussed this too in various ways previously on how just improving the neuroinflammatory ecosystem, so decreasing brain inflammation, is going to turn back the system online. And we've had ideas on, for example, hyperbaric oxygen therapy being able to do this too, but certainly things that are easier for people to take. I know you've developed a couple supplements that you have people taking that are kind of based on some of the work that's been done on neuroinflammation, correct?
Correct.
And if you don't mind giving a quick rundown of what you're doing there, as far as like what is your typical neuroinflammatory or anti-inflammatory protocol at this point?
The anti-inflammatory protocol consists of all the hormones because one of the great incomplete images that we have on hormones, we think of testosterone, estrogen, progesterone as reproductive hormones, as masculizing hormones, and so forth and so on. Well, it turns out that they are what we call pleiotropic. There are many functions, as I said about testosterone, increasing interleukin-10 and decreasing the inflammation, about estradiol dropping inflammation and also getting rid of inflammatory chemicals like beta amyloid. So the hormones are extremely important. Vitamin D, very important. Right. These are the standard hormones. Vitamin D is really a hormone.
Right.
It's called the secco hormone. It comes off of cholesterol. Anything off of cholesterol, hormone. CoQ10 comes from it, vitamin D, RAS, a whole bunch of stuff comes from it. And then we developed over the past 16 years a product that we call Brain Rescue 3, which has within it a composition that we call Brain Care 2, which is our key anti-inflammatory group of 6 components that have interaction synergy with each other. Like the key synergy is gamma tocopherol and quercetin. Let me take that back. Gamma tocopherol and NAC will drop NF-kappa B, which is the trigger for transduction of genes to generate inflammatory chemicals. We use glutathione, which is the frontline defense. We use ascorbate palmitate, which is a fat-soluble vitamin C, which upregulates the glutathione synthetase so you can make more glutathione. It has quercetin. Quercetin not only increases mitochondria, it drops NF-kappa B directly. It is an ionophore, which carries zinc into the cells. And remember, we have a system that's called superoxide dismutase, SOD system. There's a zinc, there's a magnesium, there's a copper. And if you increase it, it helps to downregulate free radicals, which create the button, or they are the thumb presser of the button that causes the microglia to become activated. So we're
what happens
working
when the microglia? What happens when
yeah,
the microglia
we're working
get
with we're working with epigenetically and also directly on it. Then we use products like pregnenolone. Pregnenolone becomes allopregnanolone. Allopregnanolone is now a pharmaceutical product called brexanolone. It is free radical scavenging, and it also downregulates the ability of reactive oxygen species and nitric oxide to form peroxynitrite, which is an incredibly damaging, pain-producing chemical. Just look at peroxynitrite, and you'll see all the damage it does. In my lecture series online, it has quite a lot on peroxynitrite. And there are natural nutraceutical products. All our products are nutraceutical other than our hormonal.
Of course.
Are nutraceutical, meaning coming from plant-based or quercetin and so forth. And I share in a paper that's called Brain Rescue 3 data sheet. It has all of the composition, and it indicates every single action that each one of the components does relative to traumatic brain injury, relative to neural inflammation. And that's readily available on the website. I want people to know that nutraceuticals really work.
Yeah. I think people forget that the idea is the synergy, and that there's so much good data on each of these types of products that you just mentioned, vitamin C and glutathione, NAC. And so what I find to be so important in clinical practice is that almost everybody, whether they have a traumatic brain injury, whether they don't, whether they have a non-traumatic brain injury or something else, we all have some sort of non-traumatic brain injury. I guess that's part of aging, is that, that all of this, what you're seeing here is there's so much related to inflammation in general, right? And so when you address inflammation, everything else is going to get better. And that's going to be your hormones. That's going to be your vitamins and minerals. That's going to be your mitochondrial function. That's going to be your gut. That's going to be everywhere. So it's, and so I always go back to that. I think that you kind of go the same way as me, is that what's driving the inflammation. And then if you can test for it, fantastic. And so like in my practice, and I know that you and I know your daughters that are practicing with you, they do a lot of testing, right? And they're actually looking at vitamins, minerals, nutrients, and gut health. I think that's mostly your daughters that are doing that part of your practice?
Yeah, my daughter Allison is a naturopath.
Right.
Who spent the last 8 years with me learning my trade in neuroendocrinology, and now she's leading the pack in neuroendocrinology. She does the GI mapping, which phenomenal. I mean, she did it on me, and we picked up 2 bugs. I didn't have any symptoms, but they're there. And when I treated it, I felt even better than I already felt.
Right.
So got to give her credit. And she's integrated the nutritional world and the with the endocrine world, or endocrine and neuroendocrinology, and her results are really good. Really good.
I mean, what I often tell my clients is that if there's time, I mean, doing nutrient gut neurotransmitter optimization is first if you can, and then you add on hormones after that. I mean, depending on the situation, you may absolutely need hormones, and sometimes if it's you actually may not. And it sounds like with some of your with your cohort of people there that are just doing neuroinflammatory things, they're actually seeing significant benefit without even going on the hormone side, which is super cool. Right. But I wanted to I dropped the conversation over here when we were talking about testosterone for a minute. So you were talking about Clomid and how using that as a way to get increased testosterone without giving testosterone directly. Right. But there are also times when you give just testosterone, and there are also times when you give both, which I found was super interesting. What is the category that you're going to give both at the same time?
Okay. When we have a client that, remember, we start everybody on Clomid unless they don't have their testicles. And so if they respond well to the Clomid, what I tell them is, look, we've quadrupled your level of testosterone. We have some people who take one pill a week and they go 3-4 times up. We only have about a dozen people like that. The majority of them need 50 milligrams every 72 hours. So if they're doing well with the Clomid, I give them the option. Your level of testosterone, fantastic. We really don't need do anything more. But if you want to experience testosterone with the Clomid, I'm game. Okay? I want people to understand that we don't know what's going to optimize their functioning unless you try. There's no way that I can, kiss their forehead and say, yeah, it's going to work for you. I don't know. So we've got to try a trial and error. So we get people who we put onto a low dose of our blended testosterone. Our blended testosterone, there are two companies that make it for us, is testosterone cypionate and testosterone propionate, 80-20. And the reason is because the biodynamics and biokinetics of each one, 36 hours and another one, depending upon who you read, 24 to 36 hours. But propionate gets into the system rapidly. It disassociates. It stays in the tissue, and then when it gets into the blood, it dissociates in 2 to 4 hours, and therefore it gets into the brain rapidly. The testosterone cypionate can take 36 hours. Okay. And, it has a half-life. It has a biological activity. It has a biokinetic activity that you need to look in different research articles on, because I haven't found one article that explained it. But anyway, we call it the hybrid protocol. They take 50 milligrams of the clomiphene every night and every 72 hours. And in the morning, they take 40 milligrams of our blended testosterone. So every third day, every 72 hours, they take in the morning 40 milligrams of blended testosterone, and at bedtime, they take 50 milligrams of Clomid. The benefit of the Clomid is based on how they respond with the luteinizing hormone. Traditionally, what happens when I give a patient just testosterone, it shuts down their production of luteinizing hormone. That's how you lose the 35 neurosteroids. But if you give them in conjunction with the testosterone, the Clomid, it keeps the signal to stimulate the pituitary to produce luteinizing hormone, follicle stimulating hormone, which goes to the Leydig and Sertoli cells and keeps them active. Otherwise, what will happen is they'll become atrophic and you'll get shrinkage of the testicles. How often do we see it? Guys who come into us who have been on testosterone, they said, yeah, my gonads are small.
They call them gonads too in the office, I'm sure.
No. I'm trying to be polite.
I know you're doing a great job, Mark, by the way.
Thanks.
You're doing a great job.
I try to be polite.
I won't tell them the joke you told me before we started. So.
Oh, thank you. It was a limerick is really what it was. A limerick.
Well, a limerick. Yeah. Okay, so
that's the hybrid.
Yeah, I love that approach. I mean, this is so the cypionate propionate combination. It's hard to find in the U.S. You have a couple compounding pharmacies that are making it yourself.
I have two compounding pharmacies. One is a manufacturer.
Okay.
So I think there are 14 in the United States. One is a manufacturer. I'll send it to you privately.
Yes.
And the other one is in Florida. It's compounding. And 5-6 years ago, I introduced them to the blend. We developed the blend with what is it called? Grove Pharmacy up in Northern California, Dana Gordon. great guy, compounding, one of the earlier compounding pharmacists in 2002. So that's when, from the reading that I was doing, finding the blends. And you can't give, as much as I wish I could give testosterone propionate by itself, it burns. So you have to find the proportion between the ratio to minimize the burn and get the response. I mean, Andrew Marr, if you've talked to him, or he might talk about it on some of the podcasts he's been on, where he says within a few hours from going from destitute to becoming back in line.
Right, the depression lifted, right?
The depression lifts.
And this is what you were talking about
before. It
before.
gets into the brain rapidly.
Right.
And then, so we've got Clomid first, and then offer the patient Clomid and testosterone in the hybrid protocol. Who gets the testosterone alone? And it's usually someone who's burnt their system out. And I just had a 43-year-old Army vet who, between the ages of 33 and 38, was on 200 milligrams testosterone cypionate every Sunday, 200 milligrams every Sunday.
Wow.
He comes to me, he's 42 years of age. He wants to get onto our program. So I see what he's been on. So what we do is we taper him down, his injectable, put him on Clomid, and it took over 6 months. His testosterone level was less than 2.
Oh, wow.
His system was shut down. So he needs to be on injectable testosterone low dose for the rest of his life, for another 50 years or whatever. And this is what we're trying to avoid. So we have it when we're on the hybrid protocol on Clomid and testosterone. We'll let them run for 5-6 months on the combination, and then we'll recommend to them that they stop the injectable and they bump up their Clomid from every 72 hours to every 48 hours for a month, and then stop it. And we'll see where their levels are.
So just stop everything and to see where things go.
Stop the injectable and the Clomid to see where they're at.
Right.
And what's going to happen if we've done our job right, and they've done their part, is that they'll just go back to where they were when they first came in.
Gotcha.
What I don't want to see is that we shut them down and they're like this 43-year-old Army vet who's producing less than 2. And that's total testosterone. In our lab, total is 280 to 1,100. And he's making 2.
That's a good, that's good to delineate, because I thought you were talking about free testosterone. Okay, so that's total testosterone.
Total testosterone. Though I don't use total testosterone, but it's the one that most people know. Total testosterone is junk. Okay?
Yeah, why?
Total
tell
testosterone, 2% of total testosterone is bioavailable. Okay, so we should be focusing on free testosterone. I had a guy from he was a veteran also. He went to 2 VA endocrinologists who told him he did not need testosterone. His levels were phenomenal. He didn't believe them because he felt like shit. I can say that word. And he goes to a civilian endocrinologist who basically says the same thing. So what were his numbers? His total testosterone was 853.
Okay.
853. His free testosterone was 4.79.
Okay. And what's normal, or what's normal for you in somebody?
Well, what the lab normal for us is 15.4 is the median.
Right.
So we want between 15 and 20.
Right.
So he was at 4.79, 853. Yeah.
Right.
And so the reason why they were responding that way was because his total testosterone was elevated, and they totally ignored the deficiency of the free testosterone, which according to our lab is 3.2. So he was at 4.97, 3.2 is the bottom.
Got it.
Okay, so the question is, what was going on?
Yes.
Why did he have such a disproportionate? Well, he was generating a lot of DHT. And DHT, if you're going from free testosterone to DHT, you more than likely have a selenium deficiency, mineral deficiency. His estradiol was a little bit up, and that's from zinc deficiency. So you put back in zinc and selenium, you put in a multi-mineral. We're deficient in minerals, you know that.
Of course.
You know, we're deficient because we're drinking water that has what minerals in it?
Well, it depends, but not much if you're getting...
Give me some water that you get off the shelf that has minerals in it.
I remineralize mine over here, so, but
yeah. I put my drops in mine too.
But you're right. We're
Here's my
totally mineral deficient. And I think this is this is really a good piece of, I think, information for people, because total testosterone and free testosterone do not always match up. And so in this case, you saw that he was producing, so he was basically burning through his testosterone to make more DHT and to also make more estradiol.
And then when you have DHT elevating and estradiol elevating with a low free testosterone, you get an increased production of sex hormone binding globulin. So free testosterone drops sex hormone binding globulin, estradiol, and DHT increase it, all in the liver. So when you know that your adequate amount of free testosterone, when you prior had an elevation in sex hormone binding globulin goes normal.
This is the thing that I see a lot in the work that in the clients that I'm working with, is their elevated sex hormone binding globulin. So do you see this mostly as a mineral deficiency? Because I often see it in people that have like high inflammatory loads as well.
Yes, anything that influences the liver, again, it goes back to liver functioning. So alcohol, certain medications, fatty liver degeneration, whether or not it's alcoholic or non-alcoholic liver degenerations will influence it. That's why we have patients who are on injectable growth hormone and their IGF-1 levels don't go up. Their binding protein 3 goes up. The most sensitive, as I told you off the clomiphene citrate story, tamoxifen and arimidex, is the IGF-1 is very sensitive to things we do to our body. So alcohol can not only stop the brain producing growth hormone, but it'll stop the liver from being stimulated by that growth hormone to make IGF-1. So these are things you need to look at. And we've picked up, a lot of people with liver-related issues, one with a hepatoma, okay? So you need to look at the liver. And there's a certain pattern in the growth hormone, GH, IGF-1, and binding protein 3. There's a pattern of that suggests something's going on with the liver.
So you're able to pick up a hepatoma using that pattern. So is this something that you can see as you're trying to optimize somebody? If somebody comes in with like low growth hormone, and then you try to start increasing their growth hormone, maybe you're using some direct stimulation, you're using growth hormone directly, and then you see that their IGF-1 is not picking up like you would expect it, kind of thing?
Right. That would be a telltale sign that either alcohol or cardiac medications are most commonly the ones. There are some blood pressure, cardiac, arrhythmal, and certain of the antibiotics, grouping of antibiotics can cause that. Let's see, the one for tuberculosis. But anyway, so you have to be cognizant of the fact that the liver is the manufacturer for a lot of things, your sex hormone binding globulin, your growth hormone parameters. And if you totally ignore that, you'll miss an opportunity to diagnose something that could be fixed now.
Right. Yeah. So on the SHBG side of things, so being produced by the liver, if it's elevated, like, one of the things that I was initially kind of trained in was that this is at least part of this. If you can decrease your SHBG, you're going to also increase your free testosterone level. But that's not always directly. That is correct. Yes.
Absolutely.
Yeah.
And the question is, the reason why I don't use any topical testosterones is because topical testosterone increases DHT production, because in the hair follicles is 5-alpha reductase, the enzyme that converts free testosterone to DHT. So if you elevate your DHT level, you're going to stimulate the liver to produce more sex hormone binding globulin. So we have cases where their estradiol is normal, but their DHT is elevated, and they've got elevated levels of sex hormone binding globulin. But we'll take it back one step. So your sex hormone binding globulin is elevated. What's wrong with that? Absolutely nothing. What they found is that sex hormone binding globulin has a receptor spot on the cell membrane where it's the sex hormone binding globulin bound to the androgen, and it still stimulates what they call the STAT receptor, which is the genetic, to turn on processes in our genetic code. So it's not just the androgen receptor receiving testosterone on the cell membrane, it's also sex hormone binding globulin. And there's an article that I sent out maybe 2 or 3 years ago, which has some nice pictures showing this in a model form.
So it's also, it's active.
Correct.
It's not like that's what people don't realize, I think, too.
Well, what they say is it forms a ligand. and the ligand usually inactivates the testosterone. That's not true.
Mm.
But the point for me is why I want the sex hormone binding globulin to be as low as can be is because I don't want to trap the testosterone below the neck. I want it to get into the brain. I want the CPU to be, washed in beautiful levels of testosterone so it can convert to DHT, which is the real activated form of testosterone, dihydrotestosterone.
Mm.
And in people who have panic attacks, or people who have fearfulness, or people with startle response, what they found is the sides of the amygdala, part of the limbic system, our emotional system, if it's deficient in testosterone DHT, you're more prone towards being easily startled or fearful. And there are articles out of the psych world, thank God, that are starting to say, hey, testosterone stops the fearfulness.
Wow.
It's not meditation, and it's not the fact that your father beat the shit out of you. It's the fact that you're deficient in a hormone that regulates how you respond to the outside world. That's the function of the amygdala and the limbic system as a whole.
Well, this goes back to what you said before with the non-traumatic brain injuries, right? This is probably deficiencies and toxicities that have arisen because of previous life experience, and now this is being manifest in the way you just described, right? So, but super interesting that the psych literature is kind of catching up that these are hormonal deficiencies that are creating some of these responses,
right.
which is super interesting. Yeah,
I'm seeing articles coming out where it was out of University of Birmingham in the United Kingdom, where what they found was in people who had treatment-resistant depression, they were put on medication to treat their depression, and they were still depressed. What they found in 61% of them, they had growth hormone deficiency. And within 1 to 2 months of putting them on to growth hormone replenishment, their depression diminished or disappeared, and they ended up with 4 benefits. They slept better, brighter minds, better interpersonal skills, and less emotionally volatile. And then the articles coming out talking about growth hormone in TBI, growth hormone in stroke. The importance of it because it helps rebuild the neural circuitry.
Yeah, let's talk about it, because I think oftentimes it gets lost in the shuffle because everybody cares about testosterone, right? And then the growth hormone axis, it starts declining in men and women at pretty increased or rapid rates. At what time frame? When does this happen for men and women?
Yeah, what is it? It's is it 14% per decade, starting at I think it's 30 years of age or 40. It's either 30 or 40. I get my testosterone growth hormone, flipped around, but as we lose growth hormone, we lose all the benefits that it does. Growth hormone helps to convert thyroid T4 to T3. So in fact, you can see people who are using injectable growth hormone who on a comprehensive thyroid panel will have elevation in TSH, deficiency of T4, and high levels of T3. And the traditional doctor will go and say, oh, they've got hypothyroidism because they only look at TSH and T4. But the real issue, it's increased to T3. And why is that important? It turns out that T3, which is produced by astrocytes, N-states, T4 to T3 conversion in astrocytes, in the brain, T3 helps to keep one of the glial cells as a stem cell. It's called OPC, oligodendrocytic precursor stem cells, or precursor cells. And when they're in the stem cell state, they generate brain-derived neurotrophic factor and brain growth factors, and they stimulate growth hormones so it keeps the inflammation lower. Growth hormone is a modulator of inflammation, so through the immune system, beautifully functioning. So thyroid, very important. Testosterone we did, growth hormone.
Yeah, so on the growth hormone side.
Amino acids.
Yeah.
Amino acids, lysine, alpha-ketoglutarate, things that we absorb from our gut, from our nutrition, they stimulate growth hormone production. Look at 3 to 4 time increase in growth hormone. There's influence on ghrelin and leptin, so regulating your body fat, regulating your set point, your nutrition. Growth hormone and epiphyseal bone, growth hormone converting to IGF-1 has a 10% crossover to insulin.
Right.
So what they're finding in people with Alzheimer's disease, because of the inflammation, their growth hormone is low, their IGF-1 is low. So what happens? They can't get glucose into the neurons, so they lose neurons.
Mm-hmm.
It's all wrapped together. There's no way of tearing it apart and saying you only need that hormone.
Yes, or only this drug or whatever, right? It's all the same. And so when you think about approaching somebody with growth hormone deficiency, and what is your approach here as far as how you optimize? Because again,
great question.
There are a lot of different ways to do this, but there's challenges depending on where you are in the world. If you want to get growth hormone, for example, and also taking growth hormone directly may not be the right thing for many people. How do you approach this?
Well, here are the things that influence growth hormone production. We already talked about estradiol, free testosterone. DHEA increases 10% in males, 15 to 20% in females. Vitamin D increases growth hormone production. So if I'm looking at someone who has a deficiency in some of these components, I will first correct those things before I jump on board with a secretagogue, okay? And we use an oral secretagogue since 2001. It went into physician hands in 2006. And what it does is it works on 5 pathways in the brain to stimulate through these 5 pathways that have been documented by pharmaceutical companies. Found, the synthetic growth hormone receptor. It doesn't have any homology or doesn't look like growth hormone releasing hormone. It could be an amino acid that will stimulate growth hormone secretion. You can drop the production of somatostatin with arginine. So if you drop if you drop somatostatin, you change the threshold of production of growth hormone up. So your body's now allowed to make more than what it was before. So we've got a ghrelin stimulator. We've got the amino acids that directly stimulate growth hormone production. So the product, dinotropin or secretropin, and they're inexpensive. And we start people on that first. If they do well, we're done. If they don't do well, then if it's indicated, we'll go to something else. They've got the semirelin, they've got the ipamorelin, they got the CJC, they got the this, they got the that, and you also have IGF-1. And I don't recommend IGF-1 because the mythology behind growth hormone is that growth hormone can cause a tumor, or it can cause growth of a tumor if you already have a cancer, which is a lot of mythology. It turns out that if you go and look at growth hormone, when it goes to the liver, it turns on 7 binding proteins. Binding protein 1, 2, 3, 4, 5, 6, 7. The one that we talk about is binding protein 3, which is the one that does most of the carrying of IGF-1. It turns out that IGF binding protein 3 and binding protein 4 are major anti-cancer products. The study that happened out of Melbourne Collaborative study back, I don't remember what year, 47,000 people with stage 4 colon cancer. The ones who had the highest level of binding protein 3 lived the longest.
Interesting. Okay.
And so when I read this, I did what I usually do and deep dive. It turns out that binding protein 3 works with P53, which is the strongest anti-cancer in our nucleus. So what the binding protein 3 does is when P53 is turned on, it starts producing more binding protein 3. And what does binding protein 3 do? It attaches to IGF-1, down-regulates it so it can't stimulate mitoses.
Got it.
So what happens is P53 and the binding protein 3 turn on P21, P23, kills the cell, apoptosis.
Interesting. So this is why.
So that's why growth hormone over IGF-1. But you can use IGF-1 for short periods.
Yeah, that was what I was guessing. Are there any specific indications when you would use IGF-1?
Sure. Post-surgical, where there's been incursion into muscles, cutting of muscles. You've got muscular atrophy from a trauma or something like that, because When we're inflamed and traumatized, you get a lot of myostatin, which is a chemical that blocks muscle production. Well, it turns out IGF-1 counters it.
I see.
So as we get older, the reason why we become atrophic in our muscles, regardless of what we're doing, is because we don't have the signal to build muscle. We've got the signal to tear it down.
Catabolic, right?
Catabolic effect. So
right.
for the either nutrients, you can use L-glutamine, L-glutamine with IGF-1, IGF-1 LR3. It's a lysine. I think it's a lysine substitution in position 3 that converts the half-life of IGF-1 from 8 to 10 minutes to 18 hours.
Okay. The dosing of IGF-1 typically is what? Is it every 72, or is it every day, or how do you typically do it?
What we have is a daily injection.
Right.
And it's, 1 milligram divided by 15. So
1/15.
1/15 of a milligram a day.
Got it. Okay. Yeah, it's super interesting. I mean, the world of hormone optimization, like everything else, is not simple, right? And this is people try to simplify these things down, but the idea really is that, at least in my perspective, and I know you agree with this, Mark, it's like, don't just do one thing because like oftentimes that's going to dysregulate everything else if you're not also looking at all the other hormone axes. And like this has been a good, I think, whirlwind tour for people on at least what hormone optimization with Dr. Gordon really looks like. And I mean, I didn't really give them a sense, but I will, like in the beginning, like before we get started, like in your bio, like what you do and how you do it. But you're like, who is your population you're working with now, and how are you, and how is your practice at this point sort of been developed, or where are you going with it, I guess is better.
Right. Well, 1995 is when I started in hormone assessment. I mean, I was my best case in late 90s. I developed depression. I had 6 head traumas before I knew anything about head traumas and hormones. I had 6 head traumas, and in my reading, that's my escape, is to read. And I came across something that suggested that I look at my hormones. I ran my hormones, and I found I was growth hormone, testosterone, and thyroid deficient. And within 90 days of starting on a full-blown protocol, everything turned around. So from 95 until about 2007, I worked with NFL, did 2 ESPN Outside the Lines, did a lot of stuff, civilians with head traumas and so forth. And then in 2009, one of the docs, emergency room docs that I had trained in hormonal optimization for my first book, was called me. Her husband is a Green Beret at Fort Bragg, and he was being looked at being discharged less than honorable after 20 some odd, what do they call it? 20 some odd deployments. And it's because of all the trauma he had. Right. So she called me and said, what can I do? So I sent her a kit, and she ran the kit, and we found a deficiency. And within 90 days, 120 days of starting on protocol, he turned around to how he was before he was insubordinate. And they ended up keeping him for another 2 cycles of enlistment, or extension of his enlistment. So in 2009, I started recruiting military and active military and veterans. And then 2014, late 2014, I meet Andrew Marr. 2015, we start him on the program. And anybody who sees the movie Quiet Explosions will know, because you're in it, will know you from the movie.
You're the best supporting actor in that movie. So I'm just one of the background guys. So
I didn't even want to be in it, to be perfectly. The producer said, you need to be in it to be credible. I said, look at all the results. All the cases. That's the credibility. It's not me. It's the end result.
Yeah, the movie's called Quiet Explosions, for those that are interested, and a fantastic documentary by Jerry Sherr, close to my last name, but with 1 R at the end. So,
I thought you guys were related. But,
everybody, I think
like
we did.
Ellis Island converted,
Yeah, all the Sherrs and all the different derivations. But so over the last, you've been basically developed your practice now, and are you only seeing veterans now? Is that
as of when my daughter came on board 8 years ago? My goal was to put all the civilians in her hands, and I ended up 2 years ago just working with the military.
Right, but you're training doctors too, right? You're training doctors all over the country in your process. So there are docs all over the U.S. and all over the world that are now Mark Gordon. I forget the name. You certify
No,
them in a certain. They're not Mark
no.
Gordon certified. There's something else.
Well, it's Millennium Health Network,
That's it.
Millennium
Yeah.
Network.
Yeah.
Okay, you know, after I'm gone, the company will still be there. Okay, so
Yes.
it's about the Millennium Network.
Yes.
We've trained in 8 different countries, and I spent time in training in Russia, in China, unfortunately, in the Southeast Asia. We have offices in Cambodia, Thailand, and Vietnam, and Singapore. I'll be back in Canada doing some training in TBI. The
Awesome.
best has finally started to come through. We're been invited by prestigious military center to go and start the process of exposing them to our science and outcome. The movie's been very instrumental in opening some of those doors. Project at Fort Bragg with their head functional
Amazing.
doctor. Yeah, it's starting
Yeah.
to. It's only 14 years that I started working with the military in 2009,
That
and
sounds about
finally,
right.
14 years later, it's starting to come to fruition. And my goal is to hand all this off to the government. You know, is to hand it off to the DoD and the VA and let them run with it.
Yeah. I
They
know.
can use our
Yeah.
software, our products, whatever.
Right. I know you've actually created software to make it very easy, right? That's another one of
Yeah,
your products.
yeah, and the the software. My daughter, it took her 18 months to become proficient and able to see a patient. 18 months of working with us. The software does it in 15 minutes.
Yeah. It's
We've got
amazing. Yeah.
97 facilities in 8 countries that are using the software. We just added Jamaica, not New York, but
I got you.
everybody thinks
The
Jamaica,
country.
New York's another country. Yeah, Jamaica, the island, man, where we have psilocybin centers. Okay, and that's been another new avenue.
I didn't realize.
Andrew
Okay.
Marr.
That's
Andrew
awesome.
Marr and his group helped to, it's Heroic Heart with Jesse Gould, Andrew Marr, Rick Perry, the prior governor of Texas, with Morgan Luttrell, who's now congressman, and a couple of other really special people, helped to put a proposal in with the state government of Texas, which is now being funded research at Baylor Medical Center.
Mm-hmm.
And they're doing research. We now have, I mean, not we, but there is now, where is it? Colorado and Oregon, who are legal for medical use. And
Right.
there's a handful, 2 handfuls of states that have now decriminalized psilocybin. And we have a church in Tennessee, which is the Church of Self-Realization. Not really, it's another name, but
Sure.
that one, everybody knows, the Church of Self-Realization, where they have ibogaine, ayahuasca. They're using
Sure.
ayahuasca. And then
Sure.
there's outside the United States, they're using ibogaine, ayahuasca,
Sure.
and
Sure.
psilocybin, microdosing, full dosing. And one of our close relationships with Jamaica is the doctor in charge, or the doc who started it, started seeing our vets and started seeing that those who had been on our protocol when they got onto their psychedelic treatment did much better in their outcome than not.
Makes sense.
Which brings us to, our experience, our sharing experience in the past, Scott, with HBOT,
Mm-hmm.
okay, where HBOT works, and because of a unique biological resiliency, some people it works really well, and that's good. That's it. And other people, like the mutual case that we had, the shared case we had, it worked really good until they stopped it, and then they reverted.
Yes.
Because they weren't able to hold the beneficial effects because the underlying inflammation was disrupted. Yeah. So people have to understand there's a whole bunch of good. In fact, in Texas, HBOT is part of our system.
Yeah, I know. I've heard
And
about
I gotta,
it.
you know about that. So I got to get you there too.
Yeah,
okay?
No, I'm excited. I mean, look, I think you're right, and I've become really emphatic about this over the years, and since we've been speaking, that you need to do both. You can't just imagine getting. I mean, sometimes, like you said, getting to a chamber is going to be all you need to do, but oftentimes to have sustainable results that last after you get out of the chamber, like you got to work on all the other things that made you required in the first place. Is what it comes down to.
Right.
It's like, it's impossible to, if you don't have the machinery to make energy effectively, if you don't have the machinery to detox well, if you don't have the hormones around to help keep things going. I mean, I think hyperbaric therapy can help to some degree, but it's not oftentimes done in a silo very well. This is what they saw in the military studies as well, where people would get better, then they would revert back, that their symptoms would recur, and you haven't seen that, which is amazing, because you're keeping people on hormones, and then also the neuroinflammatory aspects of things is being regulated because of those hormones, along with the other products that you're using. So there's a lot of synergy here. I think this, where people are going to be, I think, overwhelmed, is that there's so many different options. But I think in general, the way I think about this, and I know the way you think about this now, is that let's deal with the inflammation first before you do anything, before you get into a hyperbaric chamber, before you get on hormones. Like, let's deal with the inflammation first. And then after that, then let's see what else is required once we get there, right? And unless it's an acute injury or something, and that's just a different story. You just get them in the chamber, do what you need to do, like the educationally throwing the shit at the wall, give them all the hormones or whatever. But Mark, this has been great. I really appreciate you spending so much time with me and with the audience here. I hope that we gave everybody a little bit of a tour de force of the Dr. Mark Gordon brain, and all the papers you can cite off memory, like just snapping your fingers. But
that's what happens at 70 years of age and being on the same treatment for 28 years.
Yeah, I know. Okay? Like, you're just optimized, man.
Yeah, I'm optimized. Just working on the back now.
Yeah, go one thing at a time. Right? Keep the brain humming is the most important. So, Mark, where can people learn more about your work? Whether if they're clinicians, because I have a lot of clinicians that are listening to this, also patients. I mean, where do you want to send everybody to get more information about what you're doing?
Well, a great place to start is at our educational site, which is www.tbihelpnow.org. If you go to the science, a lot of the work that we've done with our Marines or with our annual studies, and it's raw data, it's not statistically manipulated to look good, it's raw data. You can go to the media and you'll be able to see this podcast eventually on there, along with some of the other podcasts that I've done over the years. If there are physicians who would like to be trained in what we're doing, I have spent the last 7 months building a new online educational program, which you can get through our Shopify website, which is millenniumhealthstore.com, and millenniums with 2 N's, 2 L's, 2 N's, or else email to either one of us and send it out to you.
Yeah, we'll make sure we send it all in the show notes too. So,
okay,
yeah.
And that's it. We need another 500 healthcare providers minimum to help us with this, because as the science and our results are looked at with the scrutiny it's now getting and being accepted, and that's why getting called to start this process of training, there's going to be an explosion, hopefully a breaking point, where people will be coming to you and saying, are you able to provide these services?
Right.
And saying yes is great, and very inexpensive training. We're not looking to make money to do this. In fact, the 60% of all our revenue goes to our veterans. We have over 1,000 veterans that Andrew Marr from Warrior Angel Foundation and myself have helped to get into our program to help them. And the key here is it's not lifelong. It's until you get better and then you start removing things. It's not like those happy pills that are given from day one until the last day.
Yeah.
This is as you need it.
It's beautiful. That's the idea, is that people don't need you over time, right? You're able to get them either down or completely off, or completely on minimal doses of things, and be able to just, hum away. And I think the idea that you're giving back so much to the veterans and taking that kind of profit and giving them so that more veterans can get through it's awesome. I know Andrew has been working super hard on getting people and raising the vibration and how the frequency, so everybody knows about it. So it's great stuff, Mark. I really appreciate all your work, and
thank you.
Thanks so much for what you're doing in this world. And I look forward to seeing you in person sometime soon.
Maybe Miami.
No, we'll be there. I'll be there. I'll be in Miami with you. We'll be there.
Me too.
Yeah,
okay,
I know
we'll
you
have
will.
Dinner.
Okay, sounds good. That's actually going to be on the conference, but that's fine. We'll figure it out.
All right, absolutely.
All right, take care, Mark. See you.
All right, take care.
This has been another episode of the Smarter Not Harder podcast. If you enjoyed the show, please head over to Apple Podcasts, Spotify, wherever you listen to your shows and leave us a 5-star review. This would be super helpful, and we'd be super grateful. While you're at it, go to YouTube as well and click subscribe. This is a fantastic episode with Dr. Mark Gordon. I really hope you enjoyed all the information that he was able to provide here. Such actionable data, such important information when hormone optimization is involved. Thanks again for tuning in to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. We'll see you next time.